Okay, we're recording now. This is the meeting of the Global Mini Dental Implant Association, the first prequel about the Las Vegas seminar coming up November 13th and 14th. And we just wanted to chat with you about our new Facebook group, the training exercises that we're going to be able to offer to you, and then just a little bit of a talk about some of the things that we can do. I would like to first introduce a little video for you. Hold on just a moment, and then I'll have Dr. Brower talk, and Bruce. Just go ahead and do that. I'm going to share my screen. Here we go. This is a course that we took with Dr. Brower. This will just give you an idea of what we have to offer in the Global Mini Dental Implant Association.
So it's just by percentage, and then Mac can give visibility.
Yes. Yeah, but not enough. I didn't feel.
Okay. Just an idea of what we have. Stop to share a minute here.
Sure, that's a great video. I liked it.
Yeah, thank you. Okay. Dr. Brower, I'd like to introduce you right now, President of the Global Mini Dental Implant Association, and what we can expect from our courses in November.
Sure. Well, thanks for the introduction. What I thought I'd do is just go over a lab case that I have right now because it's kind of interesting. It's the difference between, minis and conventionals is quite stark when you go to the lab side of it, and that's where a lot of people tend to struggle to find a lab that knows what they're doing and can help you do your case the way you want. A lot of people, for example, know about the all-on-4. And with the all-on-4, the lab will say, oh, come to your office, I'll do the pickup for you, I'll do all that work. And so the surgeon really just has to know how to do the surgery. But with, minis, it usually is mostly done chairside. And so a lot of it has to, have more knowledge to get started with the lab side. And if you don't know how to do the lab side, then you might do the surgery side wrong as well. So anyway, what I want to show is just this box right here that was sent to me. All of these are failed lab attempts with this particular dentist. And I have two different lowers here. There's multiple uppers inside the box. And I'm going to try and zoom in and show you that the underside of that literally just has the top of the O-balls. And that's what they expected this dentist to get and cement these minis onto. And in fact, this is the lower. This is supposed to be a fixed removable hybrid where it's supposed to have housings in there. So you can tell the lab, while they said they knew what they were doing, clearly didn't, and they really didn't know how to help this dentist who, knew how to do the surgery, but couldn't explain how to get the lab to do it. And then I got this really nice model work from the lab. I mean, it's really nice model work, but you can see how the tissue model doesn't go up to where, you know, the housings are that I placed. And then there's some conventional implants that are mixed in here with these O-balls. And these are actually larger than the O-balls placed by the restoring dentist. So they're not even mini implant O-balls, but they're much bigger than conventional implant O-balls. So there's no way to get a housing that actually fits on these. So, and I looked, and these are not a traditional, you know, analog where I could just unscrew this. So I'm not sure where they got these analogs, so I can't unscrew them to change them out. So I have to basically modify a housing that I have like this and grind it out so that I can put it on here, so that when the dentist gets it chairside, the underside is going to match. So I've done this case, I guess we did a 3D print, which I can show you here. And this is the underside. That's what it should look like. So we 3D printed, I'll pull this off here, what the model should look like. So this is what she got from the regular lab. This is actually what the patient wanted. And then we 3D printed it, sent it to her. She tried it in the mouth. You can see this is how it actually fits in the mouth, right nice and tight to the tissue. We had her do a wash on the underside, which we then scanned. So that wash of just PVS gives us a new tissue model, because it does change. If you're doing this over 2 years, this can change. So once she had that, we had her line it up the way she wanted. We said, grind out these holes in the bottom until, you know, if your midline's off a millimeter, you can just grind the holes bigger and slide it back and forth. Get it where you want it, do the wash, leave it in the mouth with the wash in, and then take the bite, the blue bite, just like that. Once we have that, we have basically, we remount the model digitally when we get it, put it back here, and then in this case, I told her right on the actual 3D print where you want this to look like. And so the first time she actually took composite and added, she made the teeth much smaller, as you could tell. So she ground on this, added this and that, just as if you were working on like a composite matrix chairside. So once she had that done, she sent us the new bite registration with the wash on the bottom, and we are able to work with that digitally just to create the next final. So we have now.
Josh, your sound has gone away for some reason. Can you hold a second here? On. Go ahead.
All right. So sorry about the volume problem there. So anyway, if you look at these initial lab changes, so this was the first one they sent her, and then this was the second one with the shorter teeth. They both were kind of okay. I mean, the lab itself does good work, but what a dramatic change in the tooth size between their first and second attempt. And they were charging the dentist every time for every, you know, thing. So it was a big difference. So once we finished this, you know, we basically created this, which these are both PMMA, you know, models. And so this is how it comes out of the actual mill, right when it comes out. And then of course you add the pink. So this is what it looks like once you add the pink. And then this is what it looks like when you add the housings. Now you can have the lab do the housings themselves, or Dr. Downs actually has a nice video and some nice pictures of how to do the pickups with different types of O-rings using rubber dam. And I do like that. Probably the only other thing I wanted to just briefly talk about is if people want to add or subtract or do some of these things, this is the product that I'm using. So I use this G11, and that's my opaquer that goes up on the PMMA. And then I use the G23, and that's the tissue color that you see right here. So this is just composite that's bonded right onto the PMMA. So you can go in and lengthen and fill in areas of the tissue if it shrinks over time. Hey, Dr. LaSorsa, good to see you there.
What's up, Josh?
Hey, I know you got some older cases, so you might want to look at this. This is GMDIA 23, and you could just buy this. Net 32, you can buy it actually, but this is what they use. Same thing as Shack and Lab uses too. This is actually the color that they like, and this is what it looks like on the model. So if the tissue shrinks, like if you look at this one, see how the tissue shrunk?
Yeah.
You can actually go in, take off the PMMA, and just take some composite bonding agent and bond this in to fill in the gaps.
You're saying on a PMMA bridge?
Yeah. Yep.
Okay.
So you could actually use it on the denture too.
I've stopped using PMMA because it tends to break at the worst times. There's never a good time for it to break.
Yeah.
So I'm using either a Trinia or a Xantax or a Trilor bar, and I can just reline it with acrylic. I can just take an impression in it and have my lab tech reline it.
Well, I'm in the cases where I want strength, I'm using the Trilor bar. And you can also realign the PMMA with acrylic if you want extra thickness. But as far as like just appearance, if let's say you had a gummy smile and you wanted to lengthen it, the pink would fill in the gummy smile in that case.
Okay.
This is another cool product. I don't know that anybody's really talking about it, but I really like it for the minis and actually full arch conversions. So what this is, these little white dots are radiographic markers. So this is thermoplastic as well. So you just heat it up, you put it in the mouth. It's a monoplane occlusion in the posterior, so you can basically get it, and these are different sizes. So you can put it in, it's a generic one. You take it out of the box, put it in the mouth. You line it up where you like the video for like a full arch edentulous case. And when you take the CT, all of these radiographic markers are how you line it up digitally on the CT scan. So there's no little stickers or anything like that. So it does everything. It does the basically the bite with it. Because
What's the name of that, Josh?
It's from Good Fit Dentures. It is a brand new product from them. I don't even think they have a name for it yet, other than it's like a radiographic marker X-ray guide. So I really, really like it. But I think these are $40. So for $40, it might be cheaper than that, to be honest. I haven't talked to them in a while, but you just take a wash on the underside, take the impression with this in the mouth, you scan it in the CT, and the lab has everything because they can scan the underside of this. They've got this for aligning it in midair, and they've got the CT alignment. So it saves a couple of steps. So for the people that are, you know, using like scan appliances, or you guys are putting the stickers on, this does it all for you. And you don't actually have to have their denture. They can walk in with no denture and use this. So I kind of like that. But those are just some kind of cool things that I've been playing around with. You know, Rick, if you got some other stuff you'd like to talk about, go for it.
Well, just I'll be happy to do that. We got, you know, a little more time, but would you tell us a little bit about the November meeting, Josh, and what we're going to be able to have there?
Sure. Well, this year, you know, I think I'm webinared out, even though we're doing this as a webinar. You know, I've watched so many webinars over the past 6 months, and you know, we're all trying to be safe. I went and checked out Vegas in July to kind of see what was going on, and at that time they had just opened up the Strip again for people to go see shows. So those opened back up. You do have to. The law right now is you have to wear a mask inside. Once you're inside a building, you're supposed to have a mask on. So I think we're going to be protected. The room we have is split up so that you can basically be 6 feet apart for everything, up to 35 people. So I think we're good there. We can get more people in if we need to, but I don't think we're going to really have a problem. Some people are driving to there. You know, I think, Rick, you said you were going to drive just because you didn't want to be on a plane with a bunch of other people. And so for that reason, I think we're going to be safe overall. But for the purposes of the meeting, we're going to try to just get some people involved through, you know, we all have to get these requirements done. So like Dr. Cribbs said that at her state, they have to have opiate training. Bruce, I just saw that there's a new one for Texas that has some additional training for you guys. Have you seen the new one that just came out for you guys? You have to have like 2 credits of something that's new this year that you didn't have to have before. So anyway, we're going to do some radiology, some infection control that you need for OSHA. We're going to do some opiate training actually on the Stella Life product, you know, showing how you can use this to get rid of the use of opiates. I'm pretty impressed with that. And then Rick, if you have anything on OraCare, reducing the need for, you know, postoperative pain medication, that would be nice to have that to talk about too.
Yeah.
So just a variety of different topics. And then, for me, I'm going to talk both days and just kind of let people come up to me the first day and ask about things they'd like to talk about. I've got so many slides and lectures I can kind of just pull from whatever people want to know and go over it there. So the second day will be a lot more of just what people want to know that actually are at the meeting versus what I think they might want to know, which is a traditional style meeting.
Yeah, sure. That sounds great. And I'm webinared out. I do want to go to Las Vegas. I want to see people in person for a change. And I think we can do it safely. And especially with the Global Mini Dental Implant Association, the advanced training you get there is second to none. I really think there's going to be value created for everybody that participates. Also, we wanted you to know that this Global Mini Dental Implant Association training Facebook site is going to be offering webinars, 30-minute long webinars, and we're going to be offering those online for people that want to come and just get training in a specific area, right, Josh?
Oh, yeah.
And those are going to be $19 a piece. We have two ways to pay for those now. One is through my Dental Sleep Balance website, which I've created a link for on the watch video at the top of the screen. Let me just show them that right now, Josh. I'm going to show them the sites. So here we go. All right. And let me just bring this up. And you will see, here's the Global Mini Dental Implant website. Okay. And here is, if we will post different types of subjects that you might be interested in, like how to do a pickup with and saving space with your cap attachments. But you can pick and choose whatever subject you want to learn, and then you can watch the video by just clicking here. This will take you to the, let me just do this on a person's view. So you want to watch the video, you can go here, and that'll take you to the purchase area where they're only $19 a piece. Or you can pay for it, each video that you want to look at, by going to a PayPal link. And that's option for those who have PayPal, okay? And we'll have other options for purchasing the different videos that Josh and I and other members of the board and experts in any field might want to present, okay?
Yeah.
Yeah.
Richard, I have a question for you.
Yeah.
Last year, when I was a brand new member of the association, and what was really nice when I signed up, there was a series of videos that Josh gave us access to, and I was just going to ask for new members, is that still going to be available?
Josh?
Yeah, the course is always on there. It's on Vimeo is where you can find it. And, I am constantly surprised. There were over 50 countries of people that have actually gone on and taken those courses. And it shocked me the first time because, I always think that it's just us here in America that are doing this stuff and that we're the only one interested. But Vimeo allows you to go in and actually track. I'll post that today, all the different places that people are taking that courses, but it's a worldwide thing. And I get a little notification every time somebody signs up and pays for it. Now, the people that came to the meeting got that access last year for free, for the time. And I constantly am actually having people pay the full price for that. And I'll show, I'll go on and log in this morning. I don't log in very often to see who's taking it, where they're at, but it's very surprising to me, the range of people that are interested in the mini implants. I've seen right now, because I do the approvals on who gets into the mini implant group, I've seen a big push in France lately of people that are either just finding out about it, about the group, or are interested in minis, and Canada. Those are the two hot spots right now for people that seem to be wanting to do more mini implant use. And I think we're pretty clear, it's like, if you got a narrow space, it's a great opportunity to do a mini. Don't do something you don't need to do with a conventional. I posted a case yesterday. I'll show the results today, where I did 4 bicortical stabilization nasal implants with a lift into the nasal space. And that I just said, that's not a case for a conventional, and it isn't. But there's other cases where, you have a heavy grinder. The Dr. LaSource, we just talked about, breakage of these PMMAs. I think I put the photo on. He flowered his all-on-6 conventional implant that was a 4.3 by 10 against the PMMA with trilurenin on the top. So the trilure PMMA did not break. The conventional implant below it did.
Yeah.
So it's crazy to me. We're always still learning. That's the biggest implant I put in the arch, and that's the one that broke.
Yeah.
And granted, that's something, Bruce, you're going to come on the 23rd, and I think a couple other people are. And we're probably going to take that flowered implant out, because that's something to kind of see how to take a conventional out without taking away a lot of bone, and actually try and replace same implant in the same spot, so that I can basically use, hopefully, a stock abutment like I did before, and reuse that without having to cut it off and remake the prosthetic. So if it works out, that's what I'm going to do. But, it's trial and error, as you all know. So
You think you can salvage that bridge?
that's the goal.
Okay. Sounds good.
That is the ultimate goal. So the bridge itself didn't fracture. It's just a
Right.
PFM bridge.
Right.
But it's shocking to me. This guy, he was an extreme grinder in advance. I'll post his photo. His dentition was there, but at the gum line. Literally, he ground the teeth flush with the gums.
Right.
And they're pretty dramatic photos. So I knew in advance that this was going to be a problem. He is on Botox. He stopped the Botox, didn't get the guard, said he would wear the store-bought one. That's when the implant flowered on the bottom.
Yeah.
So, and he's a very nice guy, but his wife is pretty fierce, so she's like, oh, this should never happen. And I'm like, well, I can't really put in a bigger implant. That's not even a mini implant. It didn't break. So I said, the prosthetic didn't break. It's not a mini implant. That didn't break. He didn't follow the guidelines we gave you both. And she's got a bunch of implants I've done for her. Just she has her natural teeth. But I had posted, on there, like, what do you do in these cases where you're at a year, 2 years, and things are breaking and they don't want to pay for the replacement? I know, like, Matt LaSorsa, you've got as many of these cases out there as I do, probably among these different offices. So after a period of time of doing these, it seems like a third of my day is spent dealing with them after they've been in the mouth for a long time.
It's always a prosthetic breakdown. It's never the surgical part. It's always the prosthetics that break down that I've seen.
Yeah, and you end up spending a lot of your day fixing instead of doing.
Yeah.
After a couple of years of doing, the first couple of years you're doing them, and then the next few years you're starting to repair them. And the longer you go, the more that takes up. But that can be a lucrative part of the practice as well. But it's about, how you present it to the patient to start with, and then how you present it to them when they come in. And that's where the experience takes a lot. And let me tell you, you can get yourself in a lot of hot water with what you say to a patient before you do the surgery and when they come in when there's an issue. And I think that is where talking to people like us at the same time is a huge deal.
Boy, that's a big deal. That is really a big deal.
That's priceless.
Yes.
Because anybody can look in a book and do a surgery right, but how do you deal with a patient that, this guy did this all on 6 just over a year ago, and now he's broken an implant, and the wife doesn't want him to pay for anything. And so that's just a matter of, like, that's when your colleagues can really help you out, give you some advice on what they've done in those situations. So, at least that if you do it and it doesn't come out right, it's no better than someone else did when in their own office, So
This is
I would like to add, just as a new member that's just been involved for a year, that my experience, I started placing implants actually in 2003, but it was very sparse. So I never really got that continuing education and didn't do it enough to really become a good implantologist. And so really connecting with this group, one of the advantages is, within this week, within the last 2 days, I've actually contacted Dr. Brower on several cases for some advice. I also contacted Dr. Downs, And, these guys are available. They'll pick up the phone. You have a question. It might seem like an overwhelming problem to you, or maybe it's something simple that you just really don't want to ask a question about. And they're just so nice. They're so happy to pick up the phone. We're all on this road, and we all start at point zero. And so it's really wonderful to have access to a variety of practitioners with different experiences that you have access to. And so I just like to add that as really the true benefit, besides just getting the in-house training and going to, say, Dr. Brower's office, or going to the events themselves. You get a network of people that you can actually call up, talk to cases about, talk about cases with, and that can provide you with insight. And as you know, pre-planning, and like Dr. Brower was talking about, what you say up front, how you handle when a problem does come up. These are all aspects that we've experienced in our regular dentistry. And when we're going into a new field, I just can't overemphasize the value of that.
Thanks.
Yeah.
Can you tell us what the tuition is for the Global Mini Dental Implant Association is, and the tuition for the meeting, and how those coordinate?
Well, I'll be honest with you. Our group isn't. I guess we haven't signed up as a nonprofit, but essentially that's how we run it as a nonprofit. So what we do is we wrap up the tuition right into the annual fee meeting, so that you can basically get your CE. You can get everything you need to know about conventional and mini implants, and when to use them and when not to use them, all at one meeting once a year. And then you get access to basically all the people that are in the group that are doing both kinds of implants at different times. And we don't have any separate fee outside the annual meeting. If you want to pay to be a member, come to the annual meeting. It's included in the fee for the most part. If you don't want to come, you can pay and be a member and just not get the CE credits, but it's the same price either way. So in my mind, we're trying to just, get by and not make money on this, and use it as a group that can help each other out as colleagues. There was an implant group this year that I actually have left because of the infighting among this American dental implant group. Different people in the group were suing each other and hiring different attorneys to fight over it, and arguing over, $400 and some a night rooms that, the president of the group rented in Hawaii for herself, when other members didn't think she should spend that, and they were kicking each other out of their own meetings. And I just thought, this is never where I want to go. And this is not the kind of group that, even though the information is good, the people that are in it cannot agree with each other enough to get along. And if they are accusing each other of, poor ethics, it's just something I don't want to be a part of. Even though I like a lot of the people in the group, I'd rather contact them outside the group than within the group. And I would like our group to not be focused on, trying to make huge amounts of money so that it becomes something that is self-serving. I really think our group is about helping each other get through, these cases in the best way we can, learning and just being, good colleagues to each other, like we were all taught to be long ago. Yeah. I got a call yesterday. We were just talking about this from a dentist in Missouri, and I was walking down. I was actually just finishing that mini implant surgery. My phone just kept buzzing in my pocket, and I go, this must be important, or something's going on, because it won't stop. So I pulled out my phone after I walked out, and he sent me this picture, and this lower lip was probably 5 times the size of this side on this side. And there was a large, hematoma in it. And I thought, because I was trained in oral surgery, and then I worked in a trauma center in Louisiana, that this patient had probably hit a steering wheel and just shown up in there. Because I used to see a lot of those in the ER where they would come in, their whole face was swollen in different parts based on where they hit the windshield, or went through the windshield, or what they hit. And it turned out that, he called me, I picked up when I saw the text, and the patient had come in the day before and asked him to remove a mucocele in his lip. And he had removed it a year prior, and it came back, or 2 years prior, and it came back. So he did it again, and this is what the patient woke up with. He called his local oral surgeon, and the oral surgeon said, "Oh, you got to sew in a Penrose drain." And I think in my mind that maybe the surgeon was trying to be helpful. Maybe he was trying to make it sound like it was a difficult thing to deal with and manage. But many of us have also treated a child and seen them get numb and bite the heck out of their lower lip, and it really swells up. It looks terrible. And this was similar to that, and I think that this was probably going to resolve just with some pressure ice and elevation, and I recommended against the drain that was recommended by the surgeon, and more just evaluated over time using those preventive measures first. And am I right? Am I wrong? I don't know. We'll know in the next couple of days. But and then I also talked about the follow-up care. But what I like is that Rick Downs has got experience with blades and subs and all kinds of stuff. And if I had one walk into my office, I could call him up and ask him, hey, what do you do with this? And Dr. LaSorsa, you had all those different offices. You're going all those places, all that staff. Frankly, you'd probably be someone I'd pick up and ask about staff. And I'm sure you'd tell me. So, yeah, I mean, we all have our little bits of unique knowledge that I think we can just help each other with that is priceless. There's no book on it. There's nothing that you can get other than a face-to-face communication. On these webinars, I don't really want to spill my guts to Dr. LaSorsa about how I lost all my staff over COVID, and is it my fault? Is it their fault? I don't know, but I know 3 offices that lost all of their staff, all of them, 100% over COVID. And I went to get my hair cut Monday, and there was one person in the salon for 9 chairs. And I mean, one person. And she was cutting the hair, answering the phone, and I asked her, I'm like, is it just early in the morning and no one's here? She's like, no, everybody quit. I'm the only person that works here anymore. And so those are the kinds of things like, you feel like a big piece of doo-doo until you actually talk to your colleagues and you find out, oh, it happened to you too? Well, I guess I'm not just a horrible boss, and that's why this happened to me. So
yeah, we'll talk about that in Las Vegas a bit when I go over infection control and the history of infection control and how to, because we were able to calm my staff down with the things that we did, and I'll show you how that was done.
Yeah. Well, interestingly too, we're all supposed to have a 1-hour annual OSHA meeting. I've taken OSHA to court and won. And I sent an email to all my staff with all my new OSHA training in it, and I make a reply back saying that they received it, so I have proof that they did their OSHA training. And that's something like, depending upon who's there, we can also do some OSHA training because, you got to have an hour every year. You got to document it. So there's just all kinds of little things like that that go into the management of the office that are not even placing implants, which is what we're trying to do, So for me, that's what the group should really be about, is just helping each other out with all kinds of issues that are not even related to, how to place an implant. That can, the procedure, I see many courses where you go and it's a cadaver or a pig jaw and you place it in that jaw. It really is not the same as in the mouth. What if this patient, is bleeding because they're on Eliquis, and what if they can't sit still because they're nervous? And, there's so many factors that go into it. The aspect of drilling a hole and placing a screw is not placement of implants. And I think that many people get started by these big kits at the courses and then never start because they don't have any good support. And I think that's really what it is just having good support. So.
Well, good. This has been helpful. You guys, I'm going to post this on our new site for training. There is a button there for people who wish to register for the November webinar, and we will get you in touch with you about mini courses that we'll present online through this new Facebook portal.
Okay. All right. Good to see you guys. I got to bow out as well.
All right, guys.
Have a good day.
For everything.
Good weekend.
You too. Bye.